Hey guys, it's Tara Marie. So I'm here at the Hangar Studios. We're about to pre-record my podcast. And I'm here with Dr. Rafael Ortiz. He's the chief of Neuro-Endovascular surgery at Lenox Hill Hospital, which is here in New York City. And doctor, we're talking about stroke. I'm really glad we're going to cover this topic because I know that the incidence of stroke is on the rise.
Absolutely. It's a very important topic to discuss, and we need to address the issues.
Yeah, because it's hitting younger and younger populations too.
Correct.
Absolutely. So stick around. Get information that could save your life. I'm Tara Marie, and I'm a fitness expert, personal trainer, and motivational strategist. Optimal health is achieved when you're balanced mentally, emotionally, physically, socially, and spiritually. My goal is to bring you information that will help you be the best version of you. Hey, well, hello and welcome to Tara Marie Live. Thank you so much for tuning in. I'm your host, Tara Marie Segundo, and I'm a fitness expert, a personal trainer, and a motivational strategist. And we're broadcasting today from the Hangar Studios right here in New York City. Now, Tara Marie Live is about mental, emotional, physical, social, and spiritual health, and I have the pleasure of talking to experts in these fields and bringing you cutting-edge information that I hope will positively affect your life. Now, today we're talking about a topic that is important for us all to understand because no one is immune to being touched by it. We're talking about stroke. There are a lot of myths out there about stroke, what it is, who's at risk, how dangerous it is to have a stroke, how much control you have over preventing a stroke. The rate of stroke among young people has been rising steadily since 1995, unfortunately. Hospitalization rates for stroke increased for women between the ages of 18 and 44, and nearly doubled for men in that age range from 1995 through 2012, according to research published in the Journal of the American Medical Association. Stroke is the fifth leading cause of death in the United States and is a major cause of serious disability for adults, as you can imagine. Check this out. Somebody in the United States has a stroke every 40 seconds. And every 4 minutes, someone dies of a stroke. Stroke costs the United States an estimated $34 billion each year. Now, this podcast is heard by people in different countries, and according to the World Health Organization, stroke is the second leading cause of death and the third leading cause of disability worldwide. So this is a problem. Stroke can happen to any person of any race or any gender at any time. And it all just depends on your risk factors. The rates of high blood pressure, type 2 diabetes, abnormal cholesterol, smoking, and drug abuse have all been on the rise in stroke patients over recent years. And when you look at lifestyle risk factors like obesity, lack of exercise, poor diet, and smoking, combined with high blood pressure, high blood sugar, and high cholesterol levels, we're set up for the perfect environment for a stroke to occur. We all need to educate ourselves to stop this downward spiral and stop the insanity. So welcome my guest, Dr. Rafael Ortiz. He's the chief of Neuro-Endovascular surgery and Interventional Neuro-Radiology at Lenox Hill Hospital in New York City and is an associate professor of neurosurgery, neurology, and radiology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He's no regular doctor. Among his numerous accolades, Dr. Ortiz was honored with a proclamation by the New York Senate in 2012 for his dedication to community education and outstanding patient care. He's also the recipient of the American Heart Association's Young Heart Award for achievements in cardiovascular science and medicine, and the American Heart Association's Tu Corazón Latino Award for dedication to patient education and community health. He was recognized as one of the Men of the Year in the city of New York by El Diario La Prensa newspaper, and he received the Leadership and Vision Award of the American Heart and Stroke Association. But that's not all. He received the Latino Trendsetter Award and was named as Castle Connolly Top Doctor and New York Times Top Doctors. 4 years in a row, he was selected to the New York Super Doctors list. Dr. Rafael Ortiz, welcome.
Thank you so much for inviting, and what an impressive introduction.
Well, it's your introduction, love. I mean, if I were you, do you ever have a bad day and go, you know what, I'm just going to get out my bio and read my bio to myself?
I'll follow your recommendation.
Do you ever do that? If I have a stroke, buddy, I'm calling you.
Well, hopefully you never have a stroke, but definitely yes. I'm very proud. When I say we, I'm talking about my team and I, about our dedication to taking care of people with stroke and aneurysms.
Yeah.
People that have bleeding in the brain, having a blockage of an artery in the brain, to reverse the symptoms and save a life. This is what we do for a living, and this is what we do every day.
Every day.
We're passionate about it. We care about it. We love to talk about it. Why? Because we need to spread the word. People need to know that there's a chronic problem that the incidence of stroke only keeps increasing.
Oh, yeah.
And we need to prevent stroke. The only way to maintain people health is prevention. Now, if someone has a stroke, yes, we have ways of helping.
Yeah.
We have medications, we have treatments, we have surgeries, we have procedures, we have many ways of helping someone, and we will talk about them here today.
And that's what I want to do, because I told you before we started, obviously cameras rolling and started taping, we were chatting, and I just told you, as I was preparing last night, I was getting, I can't believe this was the emotion I was feeling. I was getting angry. Mm-hmm. And I told you that I'm angry because everything I read, and I'm not a brain surgeon, so I defer to you, obviously, but everything I read smacked of, this doesn't have to happen. This in some cases, I understand, and we're going to talk about that. I understand in some cases, stroke is just a medical anomaly and it happens. But in most cases, when we're talking about this trend that I read about in the Journal of the American Medical Association article, that stroke has been on the rise in younger and younger populations since 1995. Those are, for the most part, preventable strokes. Would you not agree with that?
I agree 100% there. Like you said, there are some predispositions, like someone can be predisposed to developing brain aneurysms, so someone can be predisposed to having irregular heartbeats, or someone was born with a hematological condition that predisposes them to form clots. Okay. So those things are definitely more challenging to control. Right. They can be helped with medications, but they're more challenging to control. The ones that we can do something about are the ones that we should be doing something about, like eating healthier.
Yeah.
When we eat healthier, we lose weight, and by doing that, we diminish the incidence of high blood pressure, diminish the incidence of diabetes, diminish the incidence of high cholesterol. And putting that together, eating healthier and exercising, makes the person much healthier and decreasing the chance of having a stroke and or a heart attack, because they go hand in hand. Okay. It's the same risk factors for a blockage in an artery in the brain are the same risk factors for a blockage of an artery in the heart.
Okay.
There are two different types of strokes.
Well, yeah, before we do that,
yes.
For people who are listening and they go, you know what, I'm not 100% sure what a stroke is.
Yes.
Would you define stroke, please? Because I think according to the reading, a lot of people don't understand exactly what's going on in the body when there is a stroke.
You're right. And I know many people that I interact with on a daily basis that ask me, and they're very confused. Right. And they don't know if it's a problem of the heart or a problem of the brain. It's a problem of the brain. A stroke is a problem of an artery or a vein in the brain.
Okay.
And what happens, there are two types of strokes.
Okay.
There is the type of stroke in which is the most common. 85% of the strokes are due to a blockage of an artery in the brain.
Okay.
85% of them. So you have let's say a little clot that was in the arteries in the neck.
Okay.
Or the arteries inside the brain that gets formed because of poor habits of smoking and high cholesterol and diabetes and high blood pressure. So a little plaque gets formed in the artery. That plaque can get dislodged and go up to the brain.
Okay.
But the arteries in the brain are smaller than the arteries in the neck or the arteries in the chest.
Okay.
So when they get to an artery in the brain, they block the artery completely. So that part of the brain that was being supplied or fed with that artery is going to die. So that part of the brain is dead. That's what a stroke, an ischemic stroke is, a blockage of an artery in the brain.
Okay.
Now, the second type of stroke, 15% of them, is an intracranial or intracerebral hemorrhage or bleeding. It's an artery in the brain that bursts and causes bleeding inside the brain or in the surroundings of the brain, in the head. And why would this happen? The most common cause for this is high blood pressure, hypertension. So if someone develops high blood pressure, they need very tight control of the blood pressure to diminish the risk of having bleeding in the brain.
Doctor, may I ask a question?
Yes.
So with a hemorrhagic stroke, so it's only seen in the presence of high blood pressure? And the reason I ask that is because, so you're saying that it's almost like a little weakening in the wall of a blood vessel, and so it kind of outpouches. Would that be accurate? Or
So the bleeding type of stroke, within that category, there's several risk factors. The most common one, high blood pressure. Other risk factors, brain aneurysm.
Okay.
And a brain aneurysm is what you just described, an outpouching in a weak spot of the artery of the brain.
Okay.
It's like a little balloon in the artery of the brain. Imagine the tire of a car with a little bubble on the side.
Okay.
And you get concerned, I need to change the tire before it
explodes.
The same concern with an aneurysm in the brain. So not every aneurysm bleeds. Approximately 4% of people have an aneurysm in their brain walking around the street, but not 4% of people are having bleeding in the brain from an aneurysm. So it's the minority of them that bleed. Having said that, the larger the aneurysm, the higher the risk of bleeding. Like the larger the balloon, the higher the risk of bleeding. If you smoke, higher risk of bleeding. If you have uncontrolled high blood pressure, higher risk of bleeding. And the other risk factor that we cannot control is family history. If someone has a brain aneurysm and they have multiple family members with history of brain aneurysm or bleeding in the brain from an aneurysm, they are higher risk of bleeding. So those are all the factors that we take into consideration when we find that someone has an aneurysm. Remember, a lot of people now are having MRIs for many reasons unrelated to any of these issues that we're talking about. If you have a car accident, hit your head, they order an MRI. Having a headache, they're going to get an MRI. And you find an aneurysm, and then what do I do about it?
Let me ask you a question, doctor. Do you ever find a correlation between hemorrhagic stroke and heavy drinking? Heavy drinking.
Yes. We know that heavy drinking, excessive alcohol intake does increase the risk of both, of hemorrhage and of ischemic stroke, both of them.
The reason I ask is that the only person I've ever personally known who had a hemorrhagic stroke was a severe alcoholic.
Yeah.
Severe alcoholic. And I wondered if that, I just wondered if that,
That definitely has to do with it. When people are alcoholics, they have liver dysfunction.
Okay.
And the liver is necessary to create the factors in order to coagulate properly. So if someone doesn't have the normal liver function, their blood is going to be thinner. And then if they bleed, it's going to be more difficult to control it.
Okay.
That's something we know about. And, there's a lot of writings about alcohol intake. And is it good? Is it bad? Is it the amount of alcohol that should be allowed and things like that? You read papers like this every day. You're seeing in the news. Reality is excess of anything is bad. Excess of alcohol is bad. Excess of sweet food is bad. Excess of carbs is bad. Excess of fat is bad. But balance is appropriate.
Now, doctor, so again, an ischemic stroke, 85% of strokes are ischemic, and that is caused by hypertension, diabetes, high cholesterol, carotid artery disease, atrial fibrillation. So, and then the hemorrhagic stroke, also hypertension. So
yes.
people with seriously high blood pressure need to just watch it. I mean, and brain aneurysm. You say arteriovenous malformation. What is that?
That's a congenital problem. So that's something that people cannot control. They're born with it.
Okay.
It's an abnormal connection between artery and vein that should not exist.
Okay.
Normally, the arteries carry blood with pressure. You feel your pulse in your arteries. Mm-hmm. Veins don't carry blood with pressure. You don't feel a pulse in your veins. Reason for that is because in between the arteries and the veins, there are capillaries.
Okay.
And if someone has an AVM, an arteriovenous malformation, they have the arteries in that part of the brain connected directly to the veins. So there are no capillaries. So now you have blood coming with a lot of pressure going to veins that are not made to sustain that pressure. And those are the ones that have a higher tendency of bleeding.
Okay. Now, if someone Okay, what are signs and symptoms? Like if someone has, God forbid, a brain aneurysm that explodes, what are signs and symptoms? Like how would you even think that, oh, this is happening to me right now?
So like you say, most people don't know that they have an aneurysm when they present with bleeding.
Right.
So the number one symptom that they have is a severe headache, the worst headache of your life, like nothing you've ever felt before. It's not like, oh, I suffer from many headaches.
Mm-hmm.
Usually those are not related to aneurysms. Those are more common migraines or tension type headaches, cluster headaches, things like that.
Okay.
But it has to be a type of headache that is different from what you have ever experienced, and it's the worst headache of your life. And
is it one-sided, doctor, typically?
well, it depends on the location of the aneurysm.
Okay.
If the aneurysm is in the back of the head, usually they have the headache in the back. If it's on the right side, they're usually in the right side.
Got it.
So it depends on that. There are other things that someone can present with whenever they have bleeding from an aneurysm, but that's the most common. It is an emergency. And the reason why it's an emergency is because after having bleeding in the brain, approximately 40% of people die. So almost half of them die even before getting to the hospital. So of the people that survive, we need to address it quickly because they have a higher tendency of bleeding again. If someone bleeds once, they have approximately 20 to 30% chance of bleeding again in the next week or so. So if they survive the first one, what are the odds that they're going to survive the second one?
Now, if someone, again, you present just the worst headache of your life, a blinding headache, is there another symptom besides that someone would say, oh my God, I think I'm having an aneurysm explode here?
No, that's the most common is the headache. Other than that, you would think about other things like ischemic strokes. Those are the ones that you can identify with other types of symptoms like paralysis of one arm, paralysis of one leg, paralysis of the face, paralysis of half of the body, inability to speak, slurred speech, gait instability, that they're falling when walking, dizziness, vertigo, room spinning sensation. If you have one or multiple of those symptoms, then you need to be very concerned. Call 911 immediately. Go to the closest emergency room for them to address it. There's a simple way for us to remember this, an acronym called FAST, F-A-S-T, FAST. Is face droop.
Okay.
The A is for arm weakness. The S is for speech difficulty. And the T for time to call 911. FAST, face, arm, speech, call 911.
And what I was always told is, and correct this if I'm wrong, ask your loved one, say, smile at me. And if the person smiles and just one side goes up.
Correct. If remember, strokes happen 1 second to the next. That's why the word strokes, we use that word, stroke.
It's like it's a brain attack,
So it has to be something that happened 1 second to the next. Like someone cannot smile all of a sudden. Someone cannot lift an arm all of a sudden.
Ask them to,
Someone cannot walk straight all of a sudden. If it's something that is chronic or is slowly getting worse over time, over weeks or months or years, obviously that's not a stroke.
Okay.
That's something else should be addressed, but it's not a stroke. It's not an artery. An arterial problem, a blockage of an artery or a vein in the brain is going to be all of a sudden.
Okay. And again, arm weakness, have your loved one raise both arms. Notice if they can both be raised to the same extent. Ask your loved one to just say basic speech if they slur their speech, like they've been drinking. And then time, my understanding is that you've got to get them to the hospital within the first hour. Otherwise, it's really not going to be good.
Correct. It is by the minute that millions of neurons are dying when someone is having a stroke. Per minute, millions of neurons die. So they have to go to the emergency room right away for the appropriate treatment. And then it is important that people know which hospitals are the ones equipped around in their neighborhoods to do this type of procedures.
Wow, okay.
Because not every hospital has the capabilities of doing every procedure that is required to fix a stroke.
So do you recommend that people in their area, they ascertain what is it called, a stroke center or
Yes. First of all, is knowing if the hospital, the closest hospital, is a stroke center or not. That's the first thing.
Okay.
And what does a stroke center offer? A stroke center will be one that they will be able to administer TPA, clot-busting drug, in the emergency room as soon as you arrive. That they will do the necessary tests to determine if you're having a stroke or not.
Okay.
And if they suspect a stroke, to go ahead and treat it right away with the medication. It's an intravenous medication. It's a clot-busting drug, and that has been proven to be effective and has been used for more than 20 years for the treatment of stroke. Having said that, not every stroke gets better with that medicine. And that's where knowing if those hospitals in your neighborhood have a Neuro-Endovascular center.
Okay.
And that's what I do. Is doing procedures in which we navigate a catheter from the groin artery, from the artery of the leg, the femoral artery. We go through the artery of the leg, navigate the catheter into the arteries of the brain, and we open the artery.
Okay.
But it has to be done immediately. And obviously, it has to be reserved for that patient that's having a severe stroke. If someone has a mild stroke, that is just some numbness in an arm or numbness in a face, it's not appropriate to do a procedure that carries risks to open a tiny artery. It has to be an artery that is causing complete paralysis on one side of the body, that inability to speak, something called aphasia, which is inability to that language dysfunction, that they cannot speak or they cannot understand what other people are saying.
I actually heard one stroke victim. She said she had a hemorrhagic stroke. She said, in my head, I could hear myself say the words I wanted to say, but it was coming out, wow, 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 wow.
Yes.
But she knew in her head, she knew what she wanted to say.
Yes.
But it was just coming out. She could hear herself saying, rah, rah, rah. You know, it was just garbled speech.
And that's very common. That's a typical aphasia. It's when someone knows what they gotta say, but they cannot say it. And imagine being in that situation, and you see people around you, and you cannot express what you want to say, or that you're having issues, or that you're having trouble moving. So you need to go to the emergency room right away, because from one mild symptom, it can progress to major symptoms by the minute. Because if there's a small artery that is blocked, it can propagate, and a larger artery can be blocked. Not only that, it could be one of the larger arteries that has the problem, that has the stroke. But everybody is born different. So we all look different outside. We all look different inside. So our arterial tree in the brain has variations. And for some people, having a blockage of one artery would manifest with complete paralysis of one side of the body. For others, it might be mild symptoms, but they have the blockage of the major artery because they're compensating. They have good collaterals from other arteries that are compensating for that blockage and giving extra blood flow. But that's not permanent.
I have a question. You're making me think. So these people who have extra arteries and extra
circulation,
venous, would that be people who are highly conditioned, like highly trained, people who are in shape versus people who are more sedentary and their body hasn't developed the extra vascularization?
Well, we know that the active people and people that have an active lifestyle have healthier arteries, period.
Okay.
So they have a better chance that to have a good collateral than someone that has already blockages in other arteries.
Okay.
Having said that, the arterial tree, you're born with that. So some people are just predisposed. Some people are lucky that are born with the complete compensation of different arteries from the back to the front and from left to right side of the brain. Some people are not that lucky. So you don't know who you are. So you have one symptom, go to the emergency room right away. Okay,
so again, find out in your area which emergency rooms have a stroke center and a neuro-endovascular team.
Correct.
Would that be fair to say?
Correct, 100%, yes. And we, for example, us at Lenox Hill Hospital, we have affiliated with ourselves with other hospitals that do not have the capabilities of offering A through Z, all the treatments for stroke.
Okay.
So we have relationship with the emergency rooms in other hospitals, and if someone goes there, they identify that there's a stroke symptom, the person gets transferred to us for us to do the treatment.
Oh, they would physically get transferred over
yes.
to Lenox Hill?
Yes.
Okay.
Now, it's important to mention we have capabilities of what's called telestroke medicine. And with telestroke, what we do is that you have cameras and computer systems set up in different emergency rooms, and the same system talks to your phone and talks to your iPad and talks to your computer at home. So what if someone is having a stroke in a hospital in another borough of the city or elsewhere, in a suburban neighborhood, you can see the person. You can see
your hospital.
And me personally, the doctor, we can see the person in that other emergency room to see their symptoms, to see if they're paralyzed, to see their face, so that we can examine them through the camera.
Yeah.
That's one. Number two, we have accessibility. We have access to seeing their CAT scans and seeing their every test that they did in that emergency room. Because as soon as someone arrives with a stroke to the emergency room, they get a CAT scan to see if it is ischemic or hemorrhagic, bleeding or blockage. And that's important because the treatments are different. If someone has a blockage, you need to dissolve the clot. So you need to use blood thinners, you need to pull the clot out. If someone has a bleeding stroke, it's the opposite. You don't want to give blood thinners. You don't want to give the clot busting drug. So it's a different management. So the first thing is a CAT scan. And then after that, let you do what's called a CTA, which is a CAT scan with contrast, a CT angiogram.
Oh, okay.
It's a CAT scan with contrast, and that will identify the exact location of the clot.
Genius.
And most hospitals have capabilities of doing CAT scans and CAT scan with contrast, CTA.
Right.
The great majority of the hospitals.
Okay.
From that information, that's enough for us to determine, is this a stroke, yes or no? If yes, is it a blockage or a bleeding artery? And what's the next step? It should be medication alone. Is it something mild that just needs medications?
Yeah.
Or is it someone that needs a surgery or a procedure to either remove a clot,
going up through the femoral artery,
going from the femoral artery to reopen the artery?
Okay.
Or do they need an open head surgery if they have bleeding that is so severe that is causing swelling and mass effect in the brain? That's an emergency, and they would need to remove the blood right away.
This leads me to my next question. It almost, it's kind of, I guess you're going to say it depends, but is a hemorrhagic versus ischemic, is one more dangerous than the other, more deadly?
Both are bad. And for ischemic, one thing that we need to remember is like I always say, it's like real estate, location. Because depending on the location in the brain, that's the severity of the stroke. There is the brainstem, the back of the brain. That's very small. The brainstem is very thin. So if you have a stroke in the brainstem, you're going to have major symptoms and severe devastation. If you have a same size of stroke in your cortex, in the hemisphere of the brain, it might not manifest like that. It might be very mild symptoms of numbness in the face or numbness in a leg or numbness in an arm.
Okay. Very
different presentations. Now, bleeding in the brain, there's some. Actually, 1/3 of the people that have bleeding from an aneurysm, they do great. 1/3.
1/3. So 33% of people
do great
cool?
after bleeding the brain, because obviously you need to treat the aneurysm to prevent a second bleeding, but they do well because it's just a headache that they had and they presented early to the hospital. It was a small bleed that they suffered. It was not one of these devastating major bleeds, and they do great. That's why it's important to go to the hospital right away for treatment, because you want to prevent that second bleeding if they already bled once.
And didn't you say that people who have one burst aneurysm are more prone to have a second and
a second and a third? Correct.
Okay. And I thought it was interesting. One of the articles you gave me to read, it talked about, and I don't know if we've said this on the air, but we talked about it before the show, how yeah, we talked about it on the air, how people will just go in for a different reason. They'll have a CT scan, a CAT scan of their head, and they'll find that they have an unruptured aneurysm.
Correct.
And this article that you gave me to read, it's about, now, what do you do if you find out you have a big unruptured aneurysm in your head? It sounds to me like you're kind of rolling the dice, you know.
Well, but we have great treatments that are safe, and that the risk of treatment is minimal, never zero. There's always a risk with everything we do in a hospital, but minimal to a degree that is definitely recommended to treat that aneurysm to prevent bleeding at any point in their lives. I mentioned before, the aneurysm, there are several risk factors, and size is one of them.
Okay.
An aneurysm that is large is an aneurysm that should be treated. An aneurysm that is 1 millimeter, 2 millimeters, very small, it's an aneurysm that is safe to be watched if it has never ruptured before. We look at the person's age. If someone shows up with an aneurysm and they're 18 years old, they have 90 years of life ahead of them. That's someone that has a high likelihood of bleeding from the aneurysm at some point.
Is it because the aneurysm grows over time?
Because it can grow and just by odds. So if someone is going to live for the next 80 years, they have 80 years and daily risk of bleeding from the aneurysm. If we find the same aneurysm in a 90-year-old person, it's unlikely that we're going to recommend treatment.
Okay.
Because most likely, if they already have 90 years old and they never bled from this aneurysm, most likely they will survive the aneurysm and have other issues.
And you said 4% of us walking around down here have
approximately 4%.
Have aneurysms and we don't know it?
Correct.
And you know what you're making me think? What about like people who, kids who do, I don't know if you've ever seen incidents of this, but kids who do contact sports, football, things like that, where they're getting banged around, does that increase the rate of rupture?
Well, the aneurysms are very rare in children. Most aneurysms form after someone is in their 20s, 30s, 40s.
Oh,
it's very rare to find an aneurysm in a child. And usually when we see it, it has to do with either trauma that caused the aneurysm.
Like a head injury.
A head injury.
Okay.
Or something congenital, some weakness they were born with in the artery in the brain. So, but it's very rare to see a child. So children should not be afraid that because they hit their head, they're necessarily going to have an aneurysm. No. Contact sports should not be prohibited thinking that an aneurysm could happen.
No, but if the kid has an aneurysm, I'm saying, could a contact sport, something as rough and tumble as like football, things like that, could it, but you just said that incidence of aneurysms in children is quite low. I'm asking if it would burst.
It is very rare, an aneurysm in a child. So the sports are not necessarily going to predispose rupture. If you know that if a child has an aneurysm, that child is going to have the aneurysm treated. It's not someone that is going to go untreated. An adult is very different. If a child has an aneurysm, like I told you before, an 18-year-old, we find an aneurysm, that aneurysm will be treated because of the risk of bleeding at some point in their life.
Got it. Now, what is a secondary stroke?
So when someone has a stroke, and the person goes to the hospital, we treat the stroke, and let's say they do great, that we were able to reverse the symptoms, because that's the magic of these treatments, that when you reopen the artery, you can go back to your baseline, to a normal lifestyle. That wasn't feasible.
Oh, the symptoms. Wait. So you have a stroke. So someone has a stroke. They lose use of their right arm. The right side of their face droops. They've got all kinds of physical obvious symptoms. When you do the TPA, the clot busting drug,
when we do the mechanical thrombectomy, the opening the artery of the blockage, going from the femoral artery with a catheter going into the artery of the brain and opening the artery again, the symptoms can resolve completely.
Wow.
It's like magic. It's one of the most rewarding things that we do in our profession. And definitely that's the reason why we have teams of people doing this on daily basis, because to save that person, that one person that we saved that had that recovery, that means everything to us.
Yeah.
Means everything. So let's say
Is that a new thing, doctor? Because I thought back in the day, now I'm thinking back when I was a kid. I'm 53, so I was born back in 65. I can recall people, older folks who I were in my family who had strokes, and they forevermore they would kind of limp around or not have use of their arms. So is this total reversal of symptoms a new phenomena?
Yes. This is these are treatments that obviously there's an evolution of the treatment.
Okay.
In the 1980s was the first person doing some research trying to see if this was feasible, 1984. But in 2015, there was the first real evidence, research-based evidence, that you could benefit significantly more by having this type of procedure than by getting just the clot-busting drug. And
that is recent, 3 years ago.
Correct, 2015. And not only that, there has been, because remember, we're always thinking the faster the better. Every minute goes by, the brain is dying. So we have always thought that we had a very short period of time to help people, but we have demonstrated that even up to 24 hours, not in everyone, in some people, even up to 24 hours, we have a chance to reverse those symptoms. And for them to have a better outcome and better chance of having a normal life,
thank God,
and survive, than if someone only gets medications. So these are treatments called mechanical thrombectomy. That's the name of the treatment, mechanical thrombectomy.
Okay, and how is that done?
That's what I'm talking about.
Through the femoral artery. Got it.
And pulling the clot out. Or you either suck it out, aspirate it, or you will use a stent that pulls the clot out with the stent. Those are the two devices that we use currently. Other things are trying to be developed, but those are the two things that we use right now.
Understood.
So you asked me about secondary stroke.
Yeah.
So let's say that person recovers and is doing great.
And you send them home?
No, we don't. We don't send them home yet. That's why.
Okay.
Because we need to find out why they had the stroke. Because once someone has a stroke, they have a higher risk of having a second one and a third one. So we need to find out why this happened in order to decrease or eliminate the risk of having a second or a third one.
And we're talking about ischemic for this moment here.
Correct.
Yes, correct.
Correct.
Okay.
And so while they're in the hospital, we check their heart to make sure that they don't have irregular heartbeats or a clot in the heart that could have dislodged and go to the brain, because that's a very common presentation.
Okay.
We check for their diabetes, we check for high cholesterol, for high blood pressure, because those are common factors. Especially if someone is young, we also check for something called hypercoagulable disease, meaning something that they were born with in their blood, factors.
Sticky.
That makes the blood stickier. So they are more prone to form clots.
That's interesting, and that's genetic, doctor?
Correct. People are born with that.
Hypercoagulable disease. Their blood is sticky.
Correct.
Wow.
And I shared with you earlier that there is a condition that some people are born with, of some low levels of some enzymes that can predispose them to have thicker blood, and that together with vitamin deficiencies can predispose someone to have a stroke, something that you would never imagine.
That's 100% genetic. That has nothing to do with
Correct. It's someone that is eating healthy, thinking they're vegan, thinking that they will have a healthier lifestyle. But because of that enzyme deficiency and that mutation, what happens is that they don't have the normal function to make the blood a little bit thinner in the blood.
Well, are you referring to the article that you co-authored?
Yes.
Okay.
Yes.
So you co-authored. You're a busy guy. You're like busting stroke clots and writing articles. You
and sitting here with you
and chatting with me. So you co-authored an article for the American Academy of Neurology that showed a correlation between increased risk of stroke in the presence of I thought this was fascinating, a vitamin B12 deficiency in increased homocysteine levels and the MTHFR mutation. So like they found that was like the trifecta.
Correct.
Because in the article that you sent me, you were specifically referencing I think it was a 35-year-old male who was a vegetarian.
Yeah.
And he was B12 deficient. That's common for vegetarians,
Yep.
B12 deficiency. But so again, vitamin B12 deficiency, which increases in the presence of increased homocysteine levels, and the MTHFR mutation is like so explain what the MTHFR mutation is.
That's one of the things that we look for when I talk about hypercoagulable disease.
Okay.
There's several. It's a battery of tests. It's just blood tests we check for protein deficiencies. Protein C, protein S, different types of deficiencies that can make the blood thicker. And this is one of them, the MTHFR mutation, that is rare. But putting it together, like you said, with a vitamin B12 deficiency because of his eating habits, predispose him to having a stroke. We did the procedure for him. We were able to open the artery. He recovers completely and then comes back with a secondary stroke.
How soon? How quickly?
Like in 3 months because of
12.
this. And then so then the treatment for him to prevent stroke is really B12. That's it.
You know what? You know why I love that? You know why I love that? Because all the research that's coming out, like a lot of cognitive problems, people think, oh, I'm getting dementia. It's just a B12 deficiency.
Correct.
You know, and then I read this and I was like, oh my God, because B12, as we get older, it's harder and harder to absorb. And then we've got a whole population of people who are vegetarians and vegans who, you know, you get the B12 from the steak and, things like that. So I thought that was fascinating.
Yes.
So basically, you saved this guy's life with supplemental B12.
That was it. That was it.
And that lowered his homocysteine levels?
Correct. Everything went back to normal.
Yeah, and the whole crux, I thought it was interesting because the whole crux, like the conclusion of that article was, normally you guys rely on drugs for things. In this case, it was like supplements.
Yes.
It was a B12, probably a sublingual B12 supplement.
That was enough. 100%.
I thought that was fascinating. I love that article.
So when we talk about secondary stroke, that's what we're talking about, looking for the cause.
Okay.
And you mentioned earlier young people having strokes.
Yeah.
One of the things that we look for whenever someone is young, yes, we look at the heart. Yes, we look at the blood factors to make sure that the blood is not thicker. But we also look for something called a dissection. Which is a tear of the artery that can happen in the artery in the neck.
A dissection.
A dissection can happen in the carotid arteries or can happen in the arteries in the back of the neck, the vertebral arteries. Yes.
I saw something that gave me chills. I don't know if I mentioned this to you. It was on Dr. Oz, but he had women, a lot of women, who were having strokes, and they were having the stroke after having gone to the hairstylist.
Correct.
Where you put your head back in the bowl and you get your hair washed, and there's a lot of pressure there. And like if you get a single process or highlights done, your head is back in that bowl for a really long time. That creates a slight dissection.
That's what we're talking about.
Of the vertebral artery, yes?
Correct.
And then they go home after going to the hairstylist and they have a stroke. Do you know how scary that is?
That's exactly what we're talking about. And we don't know, obviously, how fragile our arteries are because everybody's different. And some people are predisposed to having dissection, some people are not. The majority of the people will never have a dissection by going to the hair salon. But there's a small group that yes. And we, when we see a young person that doesn't have the risk factors, they don't have high cholesterol, they don't have diabetes, they don't smoke, and they're actually very active and exercise. So we go through a series of questions to try to figure out why this happened. Simple things. Any trauma to the head and neck, any extreme position of the neck, like being at the hair salon and they're washing your hair, like painting a ceiling,
where you're looking up,
when you're looking up constantly, roller coaster rides, the sudden movement
around,
of the head can cause that. We see people even just running, jogging. We've seen people with dissection, lifting weights. We've seen people with dissection. Very rare. This is very rare, but we've seen it.
Is there a correlation between dissection and say, a car accident where there was a concussion, whiplash, things like that, yes?
Yes, any type of trauma to the head and neck, any sudden movement of the neck, it can cause a dissection. And the reason why this happens is in the carotid dissection, the carotid, comes from the chest, goes up the neck, and before getting to the brain, it has to go through the opening in the skull. So as it goes through the bone, the carotid is fixed in the bone, but it's mobile lower down. So if you have an extreme movement of the neck to one side or the other, but it's fixed in the bone on top, that's how the tear happens.
It's like if you've had whiplash or anything.
Correct.
So are you seeing a lot of, so the dissection, you're saying that has a lot to do with personally, from person to person, the integrity of the blood vessels?
It has to do, unless it's severe trauma. If it's severe trauma, it can happen to anybody. But I'm talking about the lady who goes to the hair salon to get her hair cut and comes home. We've seen people sneezing, getting a dissection, sneezing and coughing. So everybody's different.
And generally speaking, from the time that one has a dissection to the time of a stroke, what time frame are we looking at?
We're talking about 2 to 3 days in average. Sometimes sooner, sometimes a little bit later. Symptoms of a dissection. Symptoms: neck pain and headache. If someone has sudden neck pain and headache, need to go to the emergency room right away.
Anywhere in the neck? Front,
on the same side of the headache.
Okay.
Neck and head pain. Those are signs that maybe a dissection occurred. And if they have been doing something like extending their neck for a long period of time, roller coaster rides, chiropractic manipulation of the neck, all of those can predispose to a tear of the artery.
That's spooky. I do chiropractic. Do you do chiropractic?
No.
A lot of people do chiropractic.
No. Of the neck, no, you should not. You should stop.
Wow. And so again, you would have the pain in the neck on the same side as the headache. And is the headache precipitated by lack of blood flow because of the dissection?
The dissection itself. Remember, when someone has a headache, it's not the brain that is hurting. It's usually the coverings of the brain or the outside of the artery that is hurting. It's not the brain doesn't have any feeling. That's why you hear about people having
brain surgery
with open head, no anesthesia, because it doesn't hurt. It is the coverings of the brain, the meninges, or the outside of the artery.
Okay.
Those are the ones that have the nerves where you have sensation.
Okay, so again, if you think you have a dissection for whatever reason, you've had any kind of trauma, even if it's something as simple as you've been to the hairdresser and you heard this program, get to the ER as quickly as possible.
Correct. If you have severe neck pains and headache on the same side, together with a history of trauma or extreme movement of the neck.
And what, doctor, is a TIA, a transient ischemic attack?
So TIA, transient ischemic attack, is what people usually call a mini stroke. A mini stroke doesn't mean a small stroke. A mini stroke is a TIA. When people say, no, I had a small stroke, I had a mini stroke, that's incorrect. A small stroke is a stroke.
Okay.
Big or small is a stroke.
It'd be a stroke,
yes.
Yeah, okay.
What the TIA, what it is it says it there, transient, so it goes away, ischemic, blockage, attack. So there's a blockage of an artery that reopens. So when you do the MRI, it is normal.
Oh.
Because it reopens. So you don't have a stroke. You don't have any evidence of a stroke. But you had the stroke symptoms. And that person needs the workup of the stroke person, the same workup, to prevent a real stroke from happening. Just like that person that had the first stroke, and you want to prevent a secondary stroke, that person with the TIA, you want to prevent a first stroke.
Now, how do we know if we're having a TIA? Because it's transient, so to me that would be easily missed for someone who's not paying attention.
Stroke symptoms, same thing. In face, arm, speech. Face, arm, speech. There are many other symptoms, but those are the most common ones.
And some of them trouble seeing in one or both eyes.
Yes.
Trouble walking, loss of balance.
Yes.
Sudden. And it also, I found that women may report symptoms that are different from the common symptoms.
Yes.
Like loss of consciousness or fainting. Is that common?
Well, these are very rare symptoms of a stroke. Having said that, if, let's say someone faints,
Okay.
and they wake up and they're back to normal, they need a workup. First, the heart. They need to check their heart to make sure it's fine. They need to check and make sure that they don't have diabetes, that they don't have seizures. Seizures can present with loss of consciousness and then waking up.
Okay.
It's transient hyperexcitability of the brain. That's what a seizure is. But if all of those are normal, then yes, you look for strokes, for causes of a stroke, to see if there's any predisposition of having a stroke in the future.
So let me clear this up. So a TIA, a transient ischemic attack, is named that because it's transient. It happens and then it just passes just as mysteriously.
Yes.
And so if and when the person went for a brain scan, there would be no evidence.
No scar.
Okay. So how long does a transient ischemic attack, do the signs and symptoms last 10 minutes?
The definition is less than 30 minutes.
Less than 30
Less
minutes.
than 30 minutes, but more is common. That is 5 minutes, 10 minutes, 15 minutes of symptoms.
Oh my
and
God.
it goes away.
Okay.
Usually, these people did recognize the symptoms and went to the hospital, and when they get there, they're normal. By the time they go to the hospital, they're normal. But these people, they need an entire stroke workup, because if it is a real TIA,
Yes.
that means that there's either plaque in the neck,
Yeah.
in the carotid artery, irregular heartbeats, atrial fibrillation,
Yeah,
a
God.
clot in the heart, hypercoagulability, blood thicker, or other of the risk factors that we mentioned before: high blood pressure, diabetes, high cholesterol, smoking.
Doctor, okay, so a transient ischemic attack can last as few as 5 minutes. So
Yes, and even less.
Pay attention, because is it fair to call it a precursor to the big one?
100%.
Oh God.
Yes.
Oh shit. Oh, excuse me. So like I can't say, I'm not supposed to cut. So if you have a TIA, it's coming. It's coming. Like
You have to go to the emergency room right away, just as if you had a stroke.
Oh dear
If the
God.
symptoms are transient, it's the same as a stroke.
Ooh,
the risk of having another one in the future.
You know what scares me about that? So many people I can think of, especially young people, I can think of going, oh, it passed. It passed.
Yeah.
Do you know what I mean? Like, I can totally picture people like in our age group.
Yes.
I mean, you're 10 years younger than I am, but you get my eye. Like, we're young, we're strong, everything's cool. Oh, I just had a few weird minutes. Oh, it passed. I'm afraid I would be stupid enough to do that, to just go, oh, it passed.
No, like you said, it happens, and it's very cultural also. We see people from all different backgrounds and different cultures react different to different symptoms or doctors. Some people are very afraid of going to a doctor and finding something abnormal. So yeah, I understand it 100%, but it is important
that scares the crap out of me.
If someone has stroke symptoms, they need to go to emergency room right away,
regardless of if they pass.
Correct.
All right, now, so there's been more and more women under 40 suffer a stroke each year, and in the last 20 some years, the number has risen over 23%. What is going on? Like, what with women specifically? Why is that number?
So something very interesting. That's the same number of women that smoke, 23%.
Is that so?
Correct.
So that's a direct correlate.
Well, we know that there is a real impact with smoking because of hormonal differences between men and women.
Okay.
Women can have a more of a hypercoagulable, like I'm going to use the same word, thicker blood than men, especially during pregnancy.
During pregnancy.
After delivery.
In the postpartum period.
In the postpartum period. Menopause.
Okay.
And if they take birth control pills, which are just giving more hormones, and together with smoking, it increases the risk of stroke tremendously.
I know women who take birth control and smoke. That scares me.
Tell them to listen to this podcast.
That's very scary to me.
Yeah.
So it makes the blood so the smoking and the hormones
makes the blood thicker.
Makes the blood thicker.
Steroids make the blood thicker. You know, athletes that are using steroids now.
I did. When I competed, they're juicing.
So that makes the blood thicker. Yes, predisposes to strokes and heart attacks.
Okay, well, that's scary. All right. And listen, approximately 10 to 14%, I think that's a significant figure, of ischemic strokes occur in people 18 to 45. Now, what the hell is going on? Like, I don't understand. Like, an 18-year-old, I think that's a kid. I could have an 18-year-old little kid. You know, that's like a senior in high school. So, is that mainly the hereditary stuff, or is that due to drugs? And and I have a question about smoking. Excuse me. Is that also pot smoking? Because now that pot is getting legalized in so many states, I know a lot of people that are like just smoking weed going, oh, it relaxes me. I don't advocate for smoking anything. Yes. Because I just, for the lungs, just for the lungs alone and the esophagus. But so smoking rates, when you say smoking, you mean pot?
I mean smoking, period, everything.
Cigarettes, e-cigarettes.
Yes, because we know from the research in aneurysms that the effect is because of the smoke itself. It's not because of tobacco. It's not the effect for an aneurysm making the artery weaker is the carbon monoxide. That's the problem.
Is that e-cigarettes too, doctor?
Any
and
smoke,
vaping?
Any smoke. It has nothing to do, because one doesn't have to do with cancer. Okay. That's when people talk about tobacco this, tobacco that. It is about smoke. That makes the artery weaker.
Whoa. Okay. Now, this is just killing me. You know why this is killing me? When I was a little kid, and I know I'm kind of old, but I say this all the time. When I was a little kid, you know, born in 1965, I can remember being like a 5-year-old in 1970, seeing all my old aunts and uncles and stuff. That's where you saw stroke. That's where you saw stroke, not in young people.
And we have to say it's multiple factors. The young people having a stroke, yes, some are the ones that you cannot control, but those were the same ones having the strokes back then, because you're born with a predisposition of either thicker blood or some congenital abnormality. Having said that, dissections that we mentioned before, those are the ones that also can predispose a young person to have a stroke. But the more important is the obesity rates that we have today. Okay, we're dealing with incredible numbers of people that are overweight, obese, with diabetes, children with diabetes.
I found something for you. I have a present for you. This is from the Center of Disease Control and Prevention. Percent of children aged 2 to 5 with obesity. This is a 2015, 2016 statistic, but this is what the Center for Disease Control had. 2 to 5 years old with obesity, 13.9%.
That's incredible.
Little 2-year-old in a diaper, a baby. Children 6 to 11 with obesity, 18.4%. 12 years to 19 years, 20.6%. It's like ridiculous.
Yes, 1 in 5 is obese. That's 1 in 5 is obese, and that's unacceptable, because what happens is that obesity leads to diabetes, leads to high blood pressure, and high blood pressure and diabetes leads to kidney disease, leads to strokes, to heart attacks.
It's just sick. I mean, I don't understand. I just don't understand, because, like I said, when I was a kid, this stuff didn't happen to children or to young people. It was. Don't you agree with me? I mean, in your day and age, when you were growing up, wasn't it your old relatives
correct.
who had?
It was very rare to hear about it.
Yeah.
I agree. So I'm sure that the congenital factors haven't changed tremendously, but what has changed is the external factors like obesity and physical inactivity. Mm-hmm. Now children grow up in a home where you playing video games instead of working out, being on a bike and playing basketball outside. That's reality. It was very different before.
When I was a little kid, like I don't know the difference between like 10 years, we're 10 years apart. But like when I was a little kid, we'd come home from school. My mother would put us outside with a bicycle and a hula hoop and tell us not to come home till it was dark. Nowadays,
all of us did.
But nowadays, I have a 20-year-old nephew, and I can remember when he was a child. He's 20 now. When he was a little boy, he was a fat kid, because he was a smart little kid, and he would just do video games all day, and he'd play on the computer.
Yeah. Yes.
I don't.
It's different.
It's a different life. It's a different life.
Talking about the young, it is important to mention Moya Moya.
Oh, yes. And I want to plug your Lenox Hill Hospital. Okay, so Lenox Hill Hospital, your hospital here in New York City, is one of the only centers in the country that addresses Moya Moya?
Yes, Moya Moya is a condition in which the person gets blockages of the arteries in the brain, progressive, slowly getting, instead of being like the typical stroke, the arteries in the brain are shrinking and shrinking and shrinking and shrinking and getting smaller and smaller. And at some point, the person has a stroke.
So are you saying it's progressive?
It's progressive.
And measurable.
Yes.
But we don't, it's almost like high blood pressure is the silent killer. You don't feel it.
Yes. And it's a rare condition. However, we see a lot of it because we're a referral center for people from not just from New York, but the country and the world that fly here to get treatment for Moya Moya.
Okay.
Specifically a cerebral bypass for Moya Moya. And these people, and the term Moya Moya is a Japanese word that means puff of smoke, because that's how the arteries look after it shrinks. Tiny arteries start growing around it to be able to supply blood flow to the brain, and then it looks like a puff of smoke in the pictures of the when we do the X-rays.
Now, is it a congenital thing, or is
there are different reasons why this happens, and many times we don't find why. Some are congenital. It is not something associated to lifestyles. It's something that people were born with that risk, and in order to prevent a stroke, they would need a bypass surgery, which is giving extra blood flow from an artery that typically goes to the scalp or goes outside the head, drilling a hole in the bone and connecting that artery that goes outside to the scalp or outside the brain, connecting with an artery inside the brain to give extra blood flow.
Now, how common, because I had never heard of Moya Moya until, actually it was interesting because when you sent your notes and then I started following you guys on Twitter.
Yes.
And I started seeing stuff in the Twitter feed about it. That was my first experience. I had never heard of it. How many, like, what percentage of the population in this country? And
it is a small percentage. When we say a small percentage, even less than aneurysms. An aneurysm, I told you 4%. So we're talking about 1 to 2% of people that are going to have this at the most in a high incidence region. But if someone has a stroke or stroke symptoms, the reason why they need to go to the emergency room right away is to figure out what caused the symptoms. And many times, if it's a young person, it might be this.
So are you saying Moya Moya disease is something that someone could have and never know until he or she has a stroke?
Correct.
And then they go digging around.
Or a TIA, or a mini stroke.
Okay. So in other words, like in an aneurysm, you said in the article that you wrote about unruptured aneurysms.
Yes.
I could go in just for a random CT scan of my head and they'd find an aneurysm. For a random CT of my head, would they find Moya Moya disease, or is that something you have to look for specifically?
You need to get either an MRI to look for strokes, or a study looking at the arteries in the brain. But that your neurologist, your doctor would look for it. It cannot be something that you say,
oh, look, we found Moya Moya. Okay, so you don't just go, oh, wow, okay. All right, so that's something I'm going to look for Moya Moya, and there I found it.
It is, yes. It's looking for reasons why someone is having stroke symptoms, and then you find the Moya Moya. And then look for a center that specializes in it. Very few in the country, very few in the world. So
and you usually find it, you said, in children or in young people?
Yes, it can happen in children. It can happen in young people.
Okay.
Usually the person that gets diagnosed with Moya Moya in this country is a woman, usually of Latino descent. And usually in her 30s, 40s.
Why?
That's what the incidence that we have here in the U.S.
Wow.
Yeah, very different from in Asia, where it was first discovered or described this condition. It was young men. And, and the young men present with bleeding, and the young woman presents with ischemic strokes. So very different, even though the picture looks the same.
Presentation.
Yeah.
So do you have people then from all over this country? If you're like one of the only in the whole country coming in from Moya Moya, I imagine you'd have
Yes.
people.
Yeah, we have people from every corner of the country that come and look in. My partner, Dr. David Langer, that's what he does. He's a superb cerebral bypass surgeon that specializes in treating these type of conditions.
Again, I saw that on your Twitter feed. That was
Yes.
fascinating. So I know that, and I wanted to make a comment that about the question I had previously asked you about what the heck's going on. 10 to 14% of ischemic strokes occur in young adults. I thought it was interesting because another one of the articles you sent me about ischemic stroke and TIA in young adults said that it was interesting because it corroborates what you just said. Amongst the patients who had TIA or stroke, there were high incidence rates of hypertension, type 2 diabetes, dyslipidemia, which is, high
cholesterol.
messed up triglycerides and cholesterol, and smoking, and arterial disease, which is obviously a result of those things.
Yes.
So basically, the message I'm getting from you is, yes, it's odd that 10 to 14% of ischemic stroke occur in young adults, but it's also not a mystery.
Correct.
Because when you look at the people who are having the strokes, it's like, well, I know that they're young, but look at all the risk factors.
Yes. It's a major problem that we're dealing with in this country and all over the world. But I have to use this country because this is where we work. And we see increased rates of obesity that are intolerable.
And I don't think we said this on the air. I think we said it prior to going live. But what's interesting is death rates from stroke are down. So not as many people are dying from stroke because you're so good at fixing it, but so many more of us are having strokes. So we're just overloading your workload.
Yes, like you said, the death rates are lower because now we have better treatments. We have the mechanical thrombectomies that we didn't have before. We have the telestroke, so we have access to a larger number of the population through telestroke from other hospitals coming over to us.
Yes.
And for example, we are expanding our services to other regions. We have the telestroke process in Brooklyn, in Manhattan, in Queens, and now we're going to Westchester as well to start a new Neuro-Endovascular program, not only transferring the person from Westchester over to Lenox, but to do the procedure there as well. So we're going to start a new team that will be in Phelps Medical Center in Westchester, in Sleepy Hollow, where we will have offered this same type of treatment that we offer here at Lenox Hill Hospital. The one thing that has changed the way we evaluate someone with a stroke is new computerized software that evaluates a CAT scan.
Okay. So the doctor isn't evaluating it.
So the person gets a CAT scan.
Okay.
That with contrast, and within 5 minutes, I get an alert on my phone, on my cell phone, that says this person needs the procedure.
Your phone tells you.
Yes.
Wow.
Or this person doesn't. This person had a CAT scan 5 minutes ago, doesn't need the procedure for whatever reason, because they didn't have a stroke or because it's too late.
Oh dear. Yeah.
Or if the one that is indicated, what we look for is a small stroke that is already seen on the CAT scan with a large area of the brain that is at risk of having a stroke. Explain that. So the program sends me two pictures. A picture of the stroke.
The stroke right now.
And the stroke that it will be if you don't do anything.
Oh, so it's like a forecast?
Yes. And how is that possible? Is because they inject the contrast in your vein. So the contrast will go everywhere in your body.
Whoa.
But it will take longer to go to the areas that are at risk of having a stroke because you have the blockage.
Okay.
So the normal brain will get the contrast right away. The brain at risk will get it later. The brain that is already dead will not get the contrast. So that's how you know. That's how the computer decides. The software decides if that person should have the procedure or not.
The
mechanical thrombectomy going up the artery.
Now, I have a question. When you said, so the part of the brain that's dead, You said that when you do the, how do you say thrombectomy? How do you?
Yeah, mechanical thrombectomy.
When you do the mechanical thrombectomy, people's symptoms reverse and it's like magic. Are you saying that part of the brain comes back alive? Is that what happens?
Remember, I just described that there's a part of the brain that is normal,
Yeah.
part that is dead, and part that is at risk.
Yes.
So that's the person the one that has a lot at risk is the one that is the ideal candidate for the procedure because we will reverse the symptoms. If it's already dead, there's no fixing.
Oh.
Then it's too late.
Oh. Okay. So once that terminal damage is done,
there's no reversal.
We're done.
Yes. Now.
Oh, that's very scary.
And then you depend on physical therapy, occupational therapy, rehabilitation.
Okay, so
therapy.
that's where that comes in. I get it.
Yes, because you have a part that is already, you couldn't be reversed with a procedure or with a medication. So now intense physical therapy, intense rehabilitation and speech therapy is key. The more exercise the person performs, obviously training is really training so that the brain that is normal surrounding the part of the brain that is dead learns the activities that other part was doing.
Oh, so this is what you're saying to me? Certain parts of the brain do certain things. The body's so smart that if you train in a certain way, it'll compensate. Your brain will compensate for the parts that no longer have activity.
That's what happens.
Oh,
that's what happens.
Beautiful.
But then it depends on the size of the stroke and the location. Because if you have a stroke that was so big, then there's not much normal brain to compensate.
You know, I was going to ask you because I saw an instance of a stroke once. This is scares the crap. Like a lot of people talk about, oh, I'm scared I'm going to have a stroke and die. I'd almost be scared I'd have a stroke and live because I saw this one guy. He had a stroke. It must have been a massive stroke. He lived out the rest of his life lying in bed in a diaper.
Yes.
That was his life.
Yeah.
And people had to bring him food to eat, and he could barely talk, and he had to go to the bathroom in a bedpan. And
it's very sad. And we see extremes. We see from the person that recovers completely that we celebrate to that person that ends up, like you say, with in bed. The worst type is something called locked-in syndrome.
Locked in?
Locked in.
Okay.
It's a blockage of the basilar artery. There is the artery that goes to the brainstem in the back of the brain. That when that artery closes, the person can end up completely paralyzed.
Unable to speak?
From the eyes down.
So unable to speak is
correct.
That must be what this man had because he could blink his eyes. And
that's the only thing that they can do.
Oh.
But you can feel everything. If you're itchy, you can feel it, but you're going to tell anybody. If you are, it is, yes. We see.
What kind of stroke precipitates that? Just a massive stroke in a specific part of the brain?
In the back of the brain, yeah, in the brainstem.
Oh.
Yes, very sad. And it can happen from bleeding or it can happen from a blockage.
Well, I wanted to ask you, for stroke prevention, you've already basically mentioned the big ones: no smoking, eating healthy, working out, controlling hypertension, high blood pressure, controlling type 2 diabetes, controlling your cholesterol, and losing excess fat. Is stroke prevention different for ischemic stroke versus hemorrhagic stroke? Like, is there a different type of prevention protocol?
Not really. It's the same. It is the same.
Oh, okay.
It is the same.
Because I would imagine, I can understand where smoking would cause an ischemic stroke and also cause an aneurysm to pop.
Exactly.
Yeah. Okay,
exactly.
so it's...
And remember, many of these things, going back to the weight and the obesity issues, by losing weight, usually blood pressure comes down, diabetes is better controlled, and cholesterol improves as well. So they're all interrelated. And so eating healthy is key. Maintaining a healthy lifestyle, working out, not smoking. That's it. There's no other formula. There's no secret here.
Would you say that like 80% of strokes are preventable? Would you?
Approximately.
See, that breaks my heart.
Yeah.
That just breaks my heart then.
Approximately.
Because, you know, as a trainer, I've worked with so many overweight and obese and super, you know, there's overweight, obese, morbidly obese, and then we had to create another category because we got so big, super morbid obese.
Yeah.
And the thing is I know these people struggle. God, I know they struggle because I see them struggle. But nobody's got to be that way.
Yeah.
You don't have to be that way. And it breaks my heart.
And like you said, starting a regimen and having a coach, basically having someone that guides them through the process, exercising, with eating healthier, and to increase the adherence with following with doctors and medications. We have a system in place in our hospital called Playback Health. In which we
Yes.
And this was developed by our department to improve and enhance our communication with the patients and their family members. And what it is basically in an era in which we deal with cell phones,
Right.
and in the mobile era. In medicine, we're still very far behind. As you can see, in medicine, yes, we have a great advances in surgery. We have great advances with devices.
Yeah.
But our communication is not that great.
Between patient, family, and physician.
Correct. It's not that great. And taking advantage of the way the world works today, everything through mobile, we developed this system in which we can memorialize your medical record in a computerized way, so that it's dedicated to you specifically what you care about. It's videos about you. It's podcasts about you.
So health records are on video and podcast?
Yes, and we record our visit to the hospital, to our office.
Okay.
We show you the pertinent information. This is your aneurysm. This is the size. This is the treatment option. And you receive it on your phone. You can show it to your family members. Remember, when we go to an office, a doctor's office, you forget at least 50% of what was said. You're afraid. There's a lot of language that you don't know, and you're nervous.
Yes.
Even if it happens to me, even if you're educated on the topic, you forget about it. So now you go home, you review it again, you show it to your loved one, you show it to your doctor, to your friends,
husband,
and you determine as a group, as a family, okay, now we understand better. Okay, we want to go again and follow with the treatment. Then go to the treatment. In the treatment, we record again.
Is a videographer in there videotaping it,
No,
or is
we
it just
do
an
it
automatic?
as simple as a screen capture from the computer, from an iPad or from a phone.
Got it.
That's it. So we record your scar. This is how it looks. And if it looks, this is the red spot here is normal. If it looks different, let us know.
When did you start that?
So it has been a long project. And it's been 9 years.
It took 9 years?
9 years so far. It's still working.
Okay.
And now is when we started the real final robust product. And it enhances the communication to a degree that we can communicate not just with the general audience and general public, but also, let's say, communities in need. Let's say a community that has a different language, a different culture. Mm-hmm. For me, it's Spanish. So you have a Latino family, and the grandfather doesn't speak English. You explain it in Spanish to him.
Now, how is it translated? In other words, if the's not a Latino doctor,
we have translators, or it can be done by your nurse, it can be done by your secretary, it can be done by your doctor, can be done through translation. We have a translation system in place. You
know why else this would be great? This Playback Health is because what if I wanted to take something to my primary care doctor to show him what you said?
Correct.
You know what I mean? I can't be responsible for translating.
Correct.
Okay, and this is proprietary to Lenox Hill?
Yes, it is. Yes, it is. But we're going to expand it. Our goal is we're doing pilot studies to make sure that every kink is fixed, so that we can extend it to other hospitals.
I think that's genius. Yeah, because you're sharing amongst people.
Yes.
Yeah, because I know that you're a satellite center and you have a lot going on that other people don't in the country. But I get that with these things, you can share and you can deal with other parts of the country.
It is critical.
Now, Doctor, recovery from a stroke, you say that the most important consideration is just to be active. Don't just sit down and give up. You want to keep active because when the body's active, the brain is active. Is that accurate?
Yes, and it's important to have a real controlled setting of physical therapy, speech therapy, occupational therapy, and the sooner the therapy starts, the better. You don't want delays in that therapy because then you have a better chance of reconnecting those neurons for them to learn the functions that the other part that is not working and can take over for a better recovery. Okay.
And is there anything else besides just, again, if you think you're having a stroke or a brain aneurysm, you get to the doctor. Once it's been determined, you do what you have to do to get the treatment. And then part of the treatment, depending on, again, stroke is like real estate, you said?
Yes.
Location.
Yes.
You get the proper therapies. And obviously, for many people, that's a wake-up call to turn their lives around. I hate it. Isn't it like for most people, the first symptom of a stroke is a stroke?
Yes.
Isn't
it's
that
unfortunate, but it's reality. It's like heart attacks. It's the same.
And so then that's an invitation to turn your life around.
Yes.
Yeah. Now, we're almost done, but I want to get a word from you because I know that you've got endovascular treatment for brain cancer that you specifically treat. And again, brain tumors, both benign and malignant, are on the rise, unfortunately. We've done shows about this. Is your endovascular treatment both for malignant and benign brain tumors?
Yes. There are different types of tumors. The ones that we get involved with in the clinical trial is with the malignant brain cancer. We're talking about that very common cancer that we've seen. Glioblastoma multiforme, GBM, that we've seen very popular people recently passing away from it. And it still is incurable, so we cannot say that there's a cure, but we are trying to prolong life.
How's quality of life as you prolong it?
So that's the main thing. The main reason why this type of therapy is promising is because you, instead of having all these chemotherapy sessions on daily basis or that are systemic and that can affect, we go directly to the tumor so you don't get any systemic side effects. The medication goes straight to the tumor area. We infuse it there, and you need treatments every several months instead of having to do every day or every week. And you go back to your normal life. You get the treatment, stay in the hospital one night, the next morning you leave.
How new is this treatment, doctor?
So it is a clinical study. We have been perfecting it and looking at different modalities for more than 5 years now.
Okay.
So, but it is definitely promising. There are other ways that people are trying. People are using vaccines. People are using viruses, injections to try to attack the tumor. But we are very optimistic that maybe a combination of those treatments by using the endovascular route will be the answer.
And how is quality of life? Because again, I've Senator John McCain. Isn't if you're diagnosed with a glioblastoma multiforme, isn't it about a 15-month lifespan?
That's the average.
Average, yeah.
Yes.
And obviously, you want to get the best quality of life if you know your days are numbered. You feel like with this treatment, you enhance quality of life simply because the person isn't going in for chemotherapy and radiation constantly.
Exactly, and no systemic effects of the treatment because it's all going to the tumor. It's not going through your body.
Have you seen tumors shrink and have you extended lifespan?
Yes, we see tumors shrink. We extend lifespan. Everybody's different. Everybody's different. In some people, we have extended 1 year, 2 years, 3 years, 4 years, 5 years. So everybody's different. So we're not saying that we're curing cancer, but it is definitely an option that is very promising, and we're very optimistic about it.
And is this specific to Lenox Hill Hospital as well? Because that was the impression I got.
Specific to Lenox Hill Hospital, yes. Wow. We're a major center. Dr. John Bukvar is a brain tumor surgeon, and he develops protocols for brain cancer specifically. So we all work together.
I love this, though, the idea of attacking right to the tumor. I love that.
In order to get to the tumor, the reason why people have trouble curing brain cancer is because of the blood-brain barrier. The blood-brain barrier is what protects us from, if you get sick, if your brain doesn't get sick, it protects the molecules from crossing over. But that also makes it more difficult for the medication that we use to cross and get to the tumor. So we go with the catheter
up to the tumor, disrupt the blood-brain barrier. We inject the medication that opens the channels, and then inject the chemotherapy agent. And again, the person goes for an infusion every few months.
Yes.
And in between that time, God willing, symptoms are lessened, the headaches and such, and their life is essentially
back to normal. Yes.
Yeah, I thought that was fascinating. You gave me that article to read. I thought that was I didn't know that it was specific to Lenox Hill. I'm so glad I live in New York City. Do you know, like, I'm so thankful I live in New York City, and I'm so glad I have your cell phone number. What is something, just if you want to give a final thought, stroke, what is something we can all do or start doing right away to dramatically reduce our chance of having a stroke? Just spill it out to us.
Live a healthy life. Have the determination to lose weight, don't smoke, eat healthy, and enjoy every day of your life, because we see it every day. This thing happen to anyone, any age, any socioeconomic status, any background, any culture, and it's important to be on top of things and to be on top of your health, number one, so that you can enjoy your loved ones, so that your loved ones can enjoy you. And eating healthy, losing weight, staying active, not smoking is going to be key to be able to decrease the risk of ever suffering a stroke.
And you don't have to have a stroke unless it's a congenital thing. 80% preventable. 80%.
Yeah, agree.
All right. Well, it's time for the Tamarie's tip. And as you can expect, I already told you what I'm going to talk about, Doctor. As a personal trainer, I've worked with a lot of overweight and obese and morbidly obese and even super morbidly obese people. And the worst part about being overweight or obese is that your body suffers a lot of collateral damage that sets you up for many other diseases and health conditions. Also, it's worth considering that the longer you're overweight or obese, the more damage your body sustains, and all damage is not reversible. So this is concerning for me because obesity rates are trickling down. They're getting higher and higher, but they're trickling down to younger and younger populations. So for example, if you're an obese child or an obese young adult, by the time you're my age, by like middle age, your body has sustained damage that can dramatically shorten your lifespan and diminish your quality of life while you are alive. We know things like high blood pressure, high cholesterol, and smoking are major risk factors for stroke. About half of Americans, 49%, have at least one of these three risk factors. Overweight and obesity affects approximately 66% of Americans, so that's the majority of Americans. People who are overweight or obese have a higher incidence of risk factors of stroke and are more susceptible to death or disability due to stroke. Now, we know that obesity can increase the risk of stroke simply due to inflammation caused by excess fatty tissue. The larger than normal fat cells release chemical molecules that increase inflammation and the risk of various metabolic health disorders. This inflammation can lead to the difficulty in blood flow and the increased risk of blockage, both of which cause strokes. And it's worth noting, I think this is interesting, excess fatty tissue alone has been shown to have a significant association with risk of stroke and TIA, transient ischemic attack, independent of other vascular risk factors. So if you have no other risk factors, but you have a lot of excess fatty tissue on your body, you have an increased risk of stroke, which to me is very dangerous. Research has shown that degree of obesity is a significant risk factor for ischemic stroke, and that's regardless of gender and regardless of race. When it comes to measuring degree of obesity, people measure waist circumference, related ratios like waist to hip ratio, and BMI. Actually, waist circumference and waist to hip ratio can better predict stroke than BMI. I've talked about this before. Body mass index, BMI, is a calculation based on your height and your weight. It's like the old height-weight charts. I don't like using them because BMI as a health measure doesn't indicate what comprises the weight. Is the weight fat versus muscle? How much is fat? How much is muscle? And it doesn't indicate where on your body the excess fat is stored. Your waist circumference is easy to measure. You just get a tape measure and you measure around your waist. I recommend at the navel. It should not exceed 1/2 your height in inches. So if you're 5 feet tall, that's 60 inches. Your waist circumference should not exceed 30 inches. Waist to hip ratio is actually my favorite. It's a measure of your waist in inches compared to the measure of your waist in your hips in inches. And for both men and women, a waist to hip ratio of 1.0 or higher is considered at risk or in the danger zone for heart disease and stroke. And actually, ideally, women should be below 0.86 and men should be below 0.95. And I actually wrote a blog that explains how to calculate your waist to hip ratio. If you go to my website, taramarie.com, go to the blog, and on the blog, search waist to hip ratio, and it'll come up. It'll tell you how to take your waist to hip ratio and then how to interpret the results. As a part of the collateral damage I mentioned, overweight and obese people very often also have high blood pressure and or type 2 diabetes, as we said on the show. High blood pressure is the leading cause of stroke. Type 2 diabetes is an individual risk factor for stroke. So obviously the goal is to decrease your risk of diabetes, high blood pressure, and stroke by doing what we've already said, maintaining a healthy weight by eating well and being physically active. The American Heart Association recommends that adults get at least 150 minutes of moderate physical activity per week or 75 minutes of vigorous physical activity like intense aerobic exercise per week, and also perform muscle strengthening activities 2 days per week. So just to get started, make a goal of getting 30 minutes of physical activity, say 5 times a week. That's a great place to start. And by the way, kids, the American Heart Association recommends at least 60 minutes a day of physical activity for children. So take control of the few things in life that you can control to minimize your risk of having a stroke. Move your body as much as you can. Eat your way to losing dangerous excess body fat by eating a healthy diet and cutting out all edible food-like junk that's contributing to gaining excess fat and increasing inflammation, which increases all the collateral damage. That's my final word.
Perfect.
You like that?
You summarized it better than anybody.
Yeah. Well, when I work on the front lines with these people, you guys, that's all for today's show. That was a great show, Doctor.
Thank you.
That was a great show.
Thank you for inviting me. A pleasure being here.
If you're hearing this episode as a podcast and you want to watch the video, go to youtube.com/Tamari Live, search for the video entitled Everything You Need to Know About Stroke. You can also access my YouTube channel on my website, tamari.com. I want to thank my guest. I love you, Dr. Rafael Ortiz. For more information about Dr. Ortiz and the Neuro-Endovascular Surgery Department at Lenox Hill Hospital, visit lenoxhill.northwell.edu/neurosurgery. I'm going to say that again, lenoxhill.northwell.edu/neurosurgery. And you guys, what I'll do, Doctor, I know that that's a mouthful of a link. When we post this podcast on my website, I will link your name to that. And so people can just click on Dr. Rafael Ortiz and get straight there.
Excellent.
Please rate and review Tamari Live on iTunes and be sure to subscribe to Tamari Live so you never miss an episode. You can subscribe using iTunes or whichever podcast app you want on my website, tamari.com. Tamari Live, all episodes are posted there on tamari.com. And while you're there, sign up for my mailing list. You'll get my newsletter with my Tamari's tips about fitness, nutrition, motivation, and everything. And I'll always send out information about the latest episode of my podcast. Connect with me on Facebook and Instagram at Tamari Live and on Twitter at Tamari_live. And make better choices today than you did yesterday. And you'll always be moving in the right direction. Peace out. God bless you. Thank you, Doctor.
Thank you for inviting me.